Now imagine you're a lab and you're a reference lab and you're trying to get prior authorization from a clinic. You can't even get documentation of medical necessity. So now there's prior authorization, but these are your customers and you are tasked with delivering a service. They need that lab test done whether it's being paid for or not. And so that's a huge problem for the reference labs is they take the hit regardless. And a lot of pushback happened on the labs. They're like, hey, look, we can't control the clinics. We can't make them send us notes. We can't make them document well enough, but yet you're holding us responsible for this, and that's not fair. And the way that the payers have responded is they said, well, you are no longer required to get their notes. However, you need to have documentation, however you magically get it. You need documentation that supports medical necessity, however you get it, we don't care, but you don't necessarily have to get it from the clinic. Well, of course they have to get it from the clinic. That is until Solarian came along.
This is part 3 of a 6-part series about labs, money, and business solutions to problems that are vexing the industry. I'm Cecily Korst, and I'm here again with Mike Liu and Dr. Michael Sprintz.
Hey, Cecily.
Hey. So what is prior authorization and what is it and why do payers do it?
I'll jump on this first.
Okay.
So prior authorization is a requirement that payers have for certain services that you have to ask permission first to deliver the service and get approval for that, or else they won't pay for it. And so the concept, at least originally, was to kind of pre-authorize or to review the medical necessity need for a service
in advance
prior to agreeing to it. Now, it gets really a lot more complicated. I always look at prior authorizations as denials in advance. So where a lot of times in a fee-for-service model, which is most of our healthcare system, a provider would provide a service and bill for that service and hopefully get paid, or a payer will deny it for a number of reasons, one of which is lack of medical necessity. And that's a key thing when we talk about the reason for denial being lack of medical necessity, where often it is not that it wasn't medically necessary, it's lack of documentation of medical necessity. Again, so we're going back to the problem of documenting. And a prior authorization, it's the same issue, that except in this situation, you have to prove in advance the medical necessity for the service. And today we're talking about drug testing and medical necessity for laboratory diagnostics, specifically drug testing. So in this situation, there's a number of state Medicaid providers and some other payers that are now starting to require prior authorization before running a drug test, which is really challenging, especially when you're looking at a patient in the office. It's not an elective procedure, it's a diagnostic test that influences a provider's decision on how they're going to care for their patient. So there's challenges in that as well.
So if you think about an operational workflow, how do we set up our workflows, whether you're a factory or whether you're a doctor's office? You make your people as efficient as possible. So in healthcare, we've gotten to the point where you have one person that does the check-in and check-out, one person that does insurance verification, you've got a biller, you've got someone that is a medical assistant that does clinical documentations. Some clinics will have someone that specializes in just pharmacy phone calls, right? Prior authorization, unfortunately, touches multiple people all at the same time. It touches scheduling. It touches your EBV, eligibility, benefits, and verification. It touches your medical assistants, and it touches your provider. So Dr. Sprintz, if I were to say, if we had 30 patients come in today for drug testing, can you help me document, because I've got prior authorizations that I need to get for all 30 of these patients before they come in. Can you help me do this before clinic?
It's the idea of coming into a busy clinic, already knowing I'm slammed and I've got to see 30 patients and I've got to do all of this. And then my administrator comes to me and goes, oh yeah, by the way, here's a stack of prior authorizations that you have to fill out before your first patient comes in today.
And then I'm going to need to ask him to do that every single day. That is just for a physician-owned laboratory where that clinic is going to get paid for those services. What do you do in the case where you're a reference lab, you're a large regional metropolis lab, and you're taking samples in from 20 different clients, 20 different clinics, and you're going to get all 20 clinics, and each clinic, let's say, has 3 providers, 60 providers to help you with prior authorization. So the NASA-sized problem
It won't happen, by the way. It's not going to happen.
is the fact that there are a lot of touch points to get one authorization for a service that hasn't even occurred yet. And every single payer, like we said before, has their own payer guidelines in regards to not only medical necessity, but the frequency of testing, what will be covered, what will be not. Oh, and by the way, the system is so broken that some of them are still working by fax, because in healthcare we still do things by fax. Some of them are from an online portal. Some of them you have to get prior authorization by email. So it is fragmented. It is idiosyncratic per payer. It is very administratively burdensome. And because it needs to be on the claim, you have to bring in, if it's an HMO patient, the claim's got to have the referral number from the primary care physician. And then it's got to have the prior authorization number, which, by the way, is anywhere from 9 to 20 digits long. And then all of this has got to be in the actual clinic encounter in the EMR. And then it's got to be on the digital claim that goes out to the clearinghouse.
Now imagine you're a lab and you're a reference lab and you're trying to get prior authorization from a clinic. You can't even get documentation of medical necessity. So now there's prior authorization, but these are your customers, and you are tasked with delivering a service. They need that lab test done whether it's being paid for or not. And so that's a huge problem for the reference labs, is they take the hit regardless. And from that point, I wanted to bring up one piece of information that a lot of pushback happened on the labs. They're like, hey, look, we can't control the clinics. We can't make them send us notes. We can't make them document well enough, but yet you're holding us responsible for this, and that's not fair. And the way that the payers have responded is they said, well, you are no longer required to get their notes. However, you need to have documentation, however you magically get it. You need documentation that supports medical necessity. However you get it, we don't care, but you don't necessarily have to get it from the clinic. Well, of course they have to get it from the clinic. That is until Solarian came along, where we help bridge that gap of documentation creation and access for labs, because up until now, whatever they get from the clinic won't be detailed enough to support a prior authorization.
We're talking copy-paste.
So let's explain for everyone. Copy-paste is essentially the way that people have templated notes. They would take a note for a patient, they'd copy it, they'd paste it, they'd change the name of the patient, they'd change the date of service, and maybe they would do a little, add a little bit there, here or there, but generally it's pretty much almost the same note. And now payers, what they're doing is they have algorithms. They call it lab benefit management software. And what that does is it actually reviews claims and documentation, and it looks for consistency on these notes. So if every patient looks essentially the same for each and every note, then they will deny the claim, basically stating you're copying and pasted, cloning or templating notes. And then they'll deny the claim that way. And so you've got this problem where now you have the administrative burden on the clerical staff to submit these prior authorization requests, which oftentimes they don't understand that a prior authorization request, like we talked about in the beginning, is a denial in advance, meaning you need to argue your case of why this is medically necessary in advance. But what most labs do, and what most clinical practices do with labs, is they have a very short paragraph saying, this is the patient, this is the data service, please approve this claim. And they'll send in, again, the inadequate level of note or documentation, and over again. So now you've got your staff that you're spending money on to sit there and put in a name and a data service for that same inadequate prior auth request that they're going to send in, is going to get denied.
They've made it incredibly burdensome, and you literally have to do the work. How long do you think this takes per prior authorization to grab the referral number, pull the chart notes, put in the ICD-10 codes, put in the patient's history, if you have it, because for a new patient, you're not going to have it, then get your doctor to sign off on it. The general consensus is that your staff is going to work somewhere from 20 to 25 minutes to just complete the data gathering process and complete a form to get a prior auth without a guarantee of success. So you're paying collectively your staff or your outsourced billing company for 20 to 35 minutes worth of work in advance of something you've never even done. So this isn't even for services you've rendered. This is, oh, we're asking permission for you to pay for this.
And they've already lost money just through the process. I mean, and on average, a claim denial, an appeal of a denied claim, usually costs $25 to $31. On a $114, $150 claim, you're already spending $30 on that. That's not even the cost of delivering the service. And so it starts to become an upside down problem for the labs, and for whether it's a physician-owned lab or a clinical lab, without automation and without help in order to do that. And we also know that the majority of prior auth denials and claim denials are not appealed. So the payers know if we just wholesale deny stuff, whether it's denying the prior authorization or denying a claim, the probability statistically, they are unlikely to appeal this claim, which means we keep the money.
It is staggering. It's the beginning of the year for 2025, so the OMB and CMS just published their data for all of 2024. 1% of in-network claims that were denied were actually appealed. So people are leaving tens of billions of dollars on the table because they have no mechanism to either get the prior auth in advance or to write the appeal letters on the backside. And not only do we have a solution, it's automated. What I often tell people is, in a typical day, we will have anywhere from a 2 to 5% error rate in all of our work. A 2 to 5% error rate means that if I have to appeal 100 claims, 2 to 5% of them automatically are going to be denied because of my human error. So when you automate, you reduce human error, it gets done faster, you reduce risk, and more importantly, you're going to protect yourself by having medical necessity, prior authorization, and appeal solutions that you didn't have before.
We make it easier, and we do it right. It's that simple. That's what Solarian does. What we have found up until now, there's a lot of companies out there, and I've said this before, that they do a great job of telling you what's missing. Solarian is the only company that creates the documentation that you need in order to support your claim. We don't tell you what's missing. We give you what's missing in a compliant way.
You're basically fighting fire with fire.
Absolutely.
Fighting technology with technology.
That is exactly what we're doing. And the reality in today's world in healthcare is that if you are not adopting technology and software and automation advancements, you are in a whole mess of trouble. The probability of surviving as a business in the healthcare space is unbelievably hard without adoption and integration of technology. And that's really an important thing, that when we built Solarian, and we built it from the ground up with the understanding that we can't ask providers to do more work. We can't ask the labs to do more work. Our solution needs to take work off their plate so they can be more efficient. We adapt to our clients rather than asking them to change their workflow for us. You know, Solarian knew that, and by integrating all of this, we're able to help labs, whether you're a reference lab or a physician-owned lab, to capture revenue that you could not get any other way, and to do it in a compliant manner that actually protects both the lab and the provider. And the last part is, we know margins are tight. We know that the dollar per sample of profit that you get is essential, and no one wants to invest. And so we created Solarian, and we priced Solarian in a way that it was the most cost-effective audit solution you can. For a couple of bucks per report, to protect a $150, $200 claim makes sense. And we understood that. We're all looking to make sure that we keep margins. And that's why for us, the best way to do that is to help people get money they can't get, they couldn't get any other way, and keep the money they have. And to do that and to give them that protection at a price point that makes good financial sense for their business.
So what happens if you get a claim that isn't medically necessary?
So the way that we designed the software, because again, we built this really to be agnostic. Like, I'm happy talking with payers about this as much as any lab, any physician, Congress, whomever, because it really is about supporting appropriately necessary testing and not supporting testing that's not medically appropriate or necessary. So our software evaluates each analyte to determine whether or not there is a medically necessary reason for this patient on this date of service for this analyte. And if it's not medically necessary, then the next question is, well, why? Is it not medically necessary because there is no medically necessary reason? Or sometimes there could be an inaccurate or inappropriate coding, or there's missing information. And so what Celarian has built in are what we call biller alerts. And these are alerts that when all the information comes in and we're determining medical necessity, there may be a certain situation where it doesn't make sense. And basically, based on the information that we have, this test is not medically necessary. One of the examples that I often see are, there's a code called Z71.891. And what that means, it's for a patient who's on chronic opioid therapy. Now, if that comes in, but yet there's no opioids on the medication list, but the reason for testing is for chronic opioid therapy, well, that doesn't make sense. And therefore, if you're not on opioids, but you say that you're testing for this, that's not medically necessary. So we send an alert to the lab or to the provider and say, hey, look, is this what you meant? Because if this is what you meant, then this is not medically necessary. So it helps both from an educational standpoint, but it also helps from a revenue cycle standpoint that people are not submitting claims that we know will get denied. There's a lot of software out there that they call scrubbing claims to make sure that the claim meets all the things it needs to get approved. We have built-in functionality in our software to help assist. Now, we cannot tell a lab or a provider what codes to use, but we can say something's not right here. Look into this, review the patient's chart, have the provider review the chart and make the edits or whatever adjustments that need to be made, and then they do that. And if it's not medically necessary, we do not print a report. Yep. And that's significant. Celarian, we don't make up medical necessity when it's not there.
But we do have built-in QI/QC to help you and your staff do it appropriately. Now, we've been talking an awful lot about automation. And so when we say automation, it's just very clear that all of the standard tools for automation, whether it's an API, it's an HL7 message, it's a unilateral or bilateral connection with your EMR or LIS system, we have it.
LIS system meaning Lab Information System. Some people also call it LIMS or Lab Information Management System.
There are a lot of acronyms.
A lot of acronyms. You'd think we're the military.
But not everybody can afford an automation solution, right? So the best thing that we've built in the workflow, we talked about it earlier, how some labs may outsource billers, or some labs may have it in-house, or some may have one person dedicated to prior auth and another person dedicated to denied claims. So we've got manual processes as well. We provide clients with templates.
Templates for data, not templates for the actual product.
What we talked about earlier was the burden on a provider of getting 30 prior authorizations in a day prior to clinic. Our template is something that you can export in a CSV format or an Excel format from your practice management or electronic medical record system, and in a matter of seconds, we can generate, with the proper fields and the proper data exported from your system, we can automatically generate prior authorizations in bulk.
That's a key thing, is that what we're really talking about here is we have multiple ways of getting the data from the provider in order to create this documentation. Because the question is, well, how do we get our data to you so you can create this and get it back? And the solution for that is we have built multiple ways to integrate, to be interoperable, because again, we built Celarian from the beginning to work with your clinical workflow, not force you to work into ours. And so depending on what the lab wants to do, if they want a full bidirectional integration, absolutely no problem, we can do it. I always used to joke that we can take data all the way from clay tablets to full bidirectional data integration, right? So Moses, if you're out there, hey, look, we can take your data too. But really, it's about flexibility and being able to show up for our customer in a way that, hey, look, we'll meet you where you're at, and we can work with you however you want to share the data. We have a solution that works.
Labs are a very convoluted business. So I think what we are most proud of is the fact that whether, as we've talked about, it's a physician-owned lab, we have clients that are POLs. If it's an MSO that manages multiple labs or multiple physician-owned labs, we work with MSOs. We work with reference labs. We've worked with hospitals. We've worked with health systems. So it is flexible. It is automated. And the NASA-sized solution of having so many touch points of gathering data, we can accommodate any workflow and provide a solution, because there really is no such thing as a one-size-fits-all. Every single solution we cater is idiosyncratic to your company, to your operations, to your billing methodology, to your...
It's unique.
Yep.
And personalized and tailored.
As it should be.